Hi everyone, I'm Matt from OrthoSpaceX. Today I'm joined by Mr Sam Vollans, where we will be discussing complex elbow trauma in this edition of On The Podium Stories. So Sam, thanks for joining us today.
Pleasure.
And on the podium.
I'm honoured.
That's great. And first of all, can you tell the audience about yourself, a little bit about what you do?
Yeah, so my name's Sam. Everyone knows me as Sam. I'm an arm surgeon. I work in Leeds, which is quite a small city, but very, very busy city. And I do everything arms. So adults, children, surgery of the arm. But as you get older and your beard turns a bit more grey, you tend to subspecialise and that means my practice is gradually narrowing down. I have become, as you said at the start, more known for my elbow surgery, both in adult and children's. So yeah, elbows is a thing that I'm very fascinated about.
And when did you realise that elbows was the thing that you were fascinated in?
Well, probably when you train to be a surgeon, you do quite a lot of like general surgery for a few years. And then you make a decision you want to become a bone surgeon, orthopaedic surgeon, and then you do that for 6 years. And towards the end of that period of time, I realised I was interested in arm surgery. So I wanted to do, and in England we categorise arm surgery into shoulder and elbow, and then wrist and hand. So I was like, well, I want to do shoulder and elbow, and then after I finished my training and I was ready to take up like a senior post, like a consultant post, I joined a guy called David Stanley in Sheffield, very well known for being an elbow surgeon. And I was just completely fascinated by it. I was fascinated by why people were scared of elbow surgery. And I'm not I don't do like motorbikes or anything risky, but I was quite drawn towards the fact that people were scared of it.
Mm-hmm.
They didn't really consider it as a thing.
Yeah.
They were either shoulder surgeons or hand and wrist surgeons.
Yeah.
There was no one really that was like, I'm an elbow surgeon.
Mm.
So that drew me towards it. So yeah, it was quite late on in my training really. And then actually most of my knowledge and understanding and training has come as a consultant. So I don't want to quite call it learning on the job, but I think there is an element of that. There's certain things you'll never learn before you try it.
Yeah.
Yeah.
And what are some of the biggest challenges you face when you're treating complex elbow fractures, particularly in high energy trauma cases?
Yeah. So again, by way of introduction, the elbow should be such a simple thing, shouldn't it? It's like a hinge. And how many times in people's lives do their door hinges go wrong and you call a joiner and they take the hinge off and they put a new hinge on, or they spray some oil on it and it just works again, it stops squeaking. But actually, perhaps one of the reasons why people shy away from elbow surgery is because the outcomes of elbow injuries, even treated well, are pretty poor. And the reason why that is because the elbow, you want to reach for something, the elbow's vital. You want to feed yourself, the elbow's vital. And those two things, reaching out and feeding oneself at everyday activities, personal hygiene, carrying things, interacting with your environment, being able to reach for things on shelves, all relies on, putting the hand in the right place, and the elbow is important for that. And therefore it's complex because it gets stiff. And it has to be very, very stable to enable you to lift something heavy, otherwise your arm falls off. So it has to be both mobile, but also strong and stable. It also rotates. So to pat your dog or carry some change, carry a plate across a room, has to be able to rotate. And people forget that rotation comes from the elbow as well as the wrist. So the challenges are all based around getting an elbow that's stiff moving, getting an elbow that's not stable. And that is a real challenge, that balance of movement and stability. And I think that summarises quite nicely the problems that we face.
And when managing unstable elbow fractures, then what guides your decision between like replacement or staged procedures?
Okay, yeah. So talking about bad injuries, trauma.
Yeah.
Yeah. Okay. So when an elbow gets smashed, let's say, which is what we're talking about, complex elbow stuff, we have to consider the bones and the ligaments. We won't talk about blood vessels and nerves and everything that we're scared of and make it more complicated. But from our side, we're talking about the bony anatomy, so the hinge joint and the rotation joint,
Yeah.
speaking simply, or if you want to talk more complex, that ulnar humeral, so where the ulnar bone hits the humeral bone, that's the hinge,
Yeah.
and where the radius bone hits the humeral bone, that's the rotation joint. The radiocapitellar joint is what it's called technically.
Mm-hmm.
And we need to restore the bony anatomy so that you have a hinge that works well, that doesn't squeak like a door hinge. It moves from reaching to bending to feed oneself, and also the rotation joint so that people can, move their hand nicely and it glides nice and smoothly without clicking or crunching or is painful. But also we've got to consider the ligaments on the inside and the outside of the elbow that keep the elbow stable. And then we've also got to consider what drives the elbow. So if you think about a hinge on a door, it only works when someone opens or closes the door. Well, in the body, we want to be able to drive the elbow, bend it and extend it. So there are also pieces of bone that hold the biceps, the triceps, the rotators of the elbow. And it's really important that when we're thinking about fixing an elbow, we want to put all the bits back in the right place so that the hinges work well, put the bits that are holding the tendons that drive the elbow back in the right place and hold those so that you can move the elbow, and put the ligaments back in the right place so that when you move it doesn't drop off. And that's like when we look at an x-ray or look at a scan or see a patient in clinic, all of that's going on in our brains, thinking, how can we rebuild it, make it functional, bending and extending, and make it stable so that they can lift and do what they want to do, all within one operation.
Yeah.
And I guess coming back to your original question, you asked about how do you decide whether you're like going to try and fix or reconstruct something or chop it out and put a new hinge in, so a replacement. That's what you were saying, I think. Well, if you can't achieve all of those things, you then ask yourself, well, if I replaced this, could I make it stable? Would it move better? And I think that's where the background to that decision. When we're looking at something, are we going to replace this one because I can't get that stable, or I can't fix it in a way that's going to get it moving? That's.
And if you're fixing complex fractures as well, how do you keep that soft tissue integrity around the elbow if you have to dissect through that to fix a fracture?
Yeah.
How do you then repair that and ensure that it's a solid repair?
Yeah, I mean, and that's about knowledge and understanding of the anatomy, and not having one way of fixing every injury. So that's why I love trauma. I love planned surgery, elective surgery as we call it, but I love trauma because there's no one approach. There's no, I always, if you hear people saying, oh, I always use this approach, you kind of know they've never been in enough complex elbow cases, because I don't think I ever do the same approach for a trauma case. What we try and do is we try and work out where the joint needs to go, what the ligaments are attached to, what the muscles are attached to, and then whilst our skin incision, so when we're going in through the skin, it tends to be down the back, which is a good universal place to put it, because all the clockwork for the vessels and the nerves are kind of here. We then work in windows within that preserve the ligament attachments, the muscle attachments, so that we can put the joint back in the right place. And then on our way out, the joint's back in the right place. Now we're building the ligaments back on, we're putting the muscles and the tendons back on, so that when the patient wakes up, we have a rule, which is we fix it to move it. So the most important motto of elbow surgery is we fix it to move it. If we can't fix it in order to move it, we probably shouldn't be fixing it. Maybe we're the wrong person to fix it, or maybe fixing it's the wrong thing to do. Maybe we should be replacing it to move it. But what we know is we've got to move it. If we don't move it, you lose it. And that's a surgeon's motto again in the elbow.
Yeah. And has that always been your theory? And have you always done it that way? Has that evolved over the past few years?
Yeah.
Is it constantly evolving, or is that something that you think set now as how you view things?
Well, again, that is experience-based. So when you start, you're panicked. You fix an elbow that takes you maybe 3, 4, 5 hours. You're absolutely panicked. You're like, if this moves now, it's going to be a complete disaster. So perhaps you think, well, I'll put it in a cast or I'll put it in a sling and we won't move it. And then they end up really stiff. Your x-rays and look brilliant. So you're like, wow, look how beautifully I fixed this fracture. And then the patient comes back and they say, oh, thank you so much for what you've done for me. And you say, well, can you show me what you can do? And they're like, well, currently I've got this movement. And you're like, okay, now we need to really start working with physio. And then all these like very senior experienced surgeons who are older and wiser than me, they tell us, oh, no, you've got to move it. You've got to move it. You've got to move it. And I think over years of practice, you realise you've got to rely on what you do at the time of surgery. And then you've really got to encourage patients to move it. And other people, around the UK have learned from them, and some great surgeons say things like, if the patient looks into your eyes and sees a surgeon that's confident in them moving it, they'll move it. So if I say to you, Matt, everything's gone really well, we've got a really solid fix on it, now it's up to you, you've got to move that elbow. What are you going to do? The elbow. You've got to move the elbow. Whereas if I say to you, oh, it's really difficult, took a long time, I think we've got a good fix on it, but we've just got to be careful. What are you going to do?
Sling on.
You're going to keep the sling on. And so I think part of our job as surgeons in general is to not fib and not mislead, but to really have confidence in what we do, so that when patients rehab the injury, they can rely on what we've told them.
Yeah.
And that's a really important part of our practice.
Okay, excellent. And how important is implant design and versatility of different implants when managing these kind of complex fractures?
Really vital. So I think we've seen a lot of progress in implants. If we talk just about fixation devices, so things, plates and screws essentially, as what people would know them as. If we look at the evolution of plates and screws over the last 10, 15 years, it's really fascinating. You have companies like Acumed, so the OG elbow fixation company. If you did elbows and you didn't have a set of Acumed on the shelf, then you weren't an elbow fixer. So all the big units around the UK would have had an Acumed kit or a contract Acumed on the shelf. Fantastic company. And then over the last 10, 15 years, you've had little pop-up companies or current companies that never offered peri-articular, meaning plates around the elbow joint, offerings. They've come through and developed titanium plates with screws that you can put through the plate to capture bone fragments, or actually screws that lock into the plate, so locking screws. Other companies have popped up, and then as surgeons have said, oh, do you know what, it'd be really good to have a plate that goes down the back, but I can fire a screw in from the side. And then, there you go. A company develops a plate that goes down the back with a screw that goes through the side. And then people are like, well, what would be really good is having a system whereby when I fixed it and it's still unstable, it'd be really nice to have an X-Fix, which is like a device we put on the outside to hold the elbow joint. But do you know what would be even nicer? Having an X-Fix that was on the inside, like an in-fix, and then a company come along and say, well, we'll develop that. And then their whole brand is based around an external fixator that lives under the skin. And there's loads of examples of really good innovation in elbow surgery. And a number of companies have some fantastic devices. And therefore it's really important in my opinion, and I differ from other surgeons around the UK, but it's really important to have never be aligned to a company, be aligned to the product, be aligned to the product that does the job that you need it to do. And if you look at a problem, you look at an x-ray or a patient, and you in your head you make that process, how am I going to fix it, how am I going to make it stable, how am I going to move it, and you think that the device that you've got on the shelf can't do all of that, you have to look at the strengths of other products.
Yeah. And do you see these companies, new companies coming into the market offering more innovative niche products, or is it more of an evolution of current systems to make them a little bit more suitable for the modern day?
I think it's both. So I think it's really good to see pop-up companies who have like seen a gap in the market or a real use for patients, and then they design something and bring it to market. Fantastic. But I think every company really that's serious about elbow trauma is evolving. So look at Acumed, for example. Acumed, OG, they've had the same system for years and years and years. They've just tweaked their screw design, how the sizes of screws, because perhaps the feedback was a 3.5 millimeter screw, which we call like a small fragment size screw, might be too big for some of the smaller fragments. So over the last 5-10 years, they've got more. Let's design a platform system that takes 2 mil screws, 2.7 mil screws. So they're going smaller, that variability. But then, other companies bring out lower profile plates, more plating options. And then Acumed say, well, actually, we can do that. If people want that, we'll progress that. And other companies trying to match their competitors. So I'm not someone that shies away from talking about the commercial aspects of what we do as surgeons. And I think it's great that companies look over the fence and say, well this company have a really strong product, but we have a product that we can evolve and push forward. Radial head replacement's a really good example. Acumed again was, I'm probably wrong, but for me as a training at my age, Acumed was the only prosthesis that we were ever taught on. And it's an anatomic design. And then other people came out and said, well, actually, should we be using anatomic radial heads, or should we just be using a circular thing? And then various other companies, Stryker, DePuy, all the big companies, they have their own radial head system. And then, Acumed were like, we're the only ones with a long stem. Let's develop. And it's just fascinating.
Kind of forces innovation across each company, doesn't it?
Yeah, it's great. And it's really good. I love meeting companies. And that's, in a way, like an encouragement to you as an organisation. It's great what you do, because you're speaking to surgeons that have different practices. We work with different companies. I do happen to have a set of Acumed, kit on the shelf. I use their radial head, I use their elbow plate products. But equally, the commercial side, as you know, big hospitals like Leeds, we do tenders, so legal processes where we sign contracts with big companies. And as you know, we are aligned to Synthes, which is DePuy, Johnson & Johnson, massive company. And that's great. And they're great for some things, but they have gaps where Acumed is required. And similarly, Acumed don't have products that they have. So we have to use them, for leg surgery. I don't do a lot of leg surgery, but Acumed don't have the options around the knee or the hip that Synthes are just well known for. So it's fascinating, and I don't think we should shy away from it either. So I don't think we should shy away from engaging with industry, engaging with innovation. But as a surgeon, it's really important that companies listen to surgeons, see where the gaps are, and innovate with them.
Rather than pushing their own agenda, I think you've got to listen to the surgeons who are using the products. And
exactly. And it's really important that we hear surgeons talking about what they think work well. So if a company's coming to you saying they've got the best products in sliced bread, then we're not going to go, oh great, I love sliced bread. You're going to go, well, who else eats your sliced bread? And you say, is their sliced bread any good? And they say, yeah, fantastic. I use it all the time. These are my results. And you're like, brilliant. I might start eating your sliced bread as well. But if you have a company that's singing about products which no one's using, and or has used, and they're like, these are the difficulties I found. I think it's really important. That's why networking is really important as well. It's great to put things out there like this. What works well, what doesn't.
Yeah. Excellent. And is there any particular case that stands out in your memory, one that's really tested your surgical planning and fixation strategy for complex elbow trauma?
Yeah, so I think the ones that are the most complex are the ones that you go into hoping that you're going to be able to fix, and you can't, I think. So it kind of takes you down a different route. So I remember a guy very soon after I started who had been ejected through his windscreen of a lorry on the A1, very young, which suddenly you're thinking, he's so young, we can't possibly replace. So we can't replace his elbow. He's left part of his elbow on the road, so we can't put that back inside him. So we have to fix. And then we have a fantastic trauma unit in Leeds of some fantastic surgeons, and someone had taken him to theatre to try and fix him, and got to a certain point during the operation, 3-4 hours in, and was like, I can't fix this. So come back another day, me thinking, well, if anyone can fix him, this is the nature of surgery. You feel like if anyone can fix him, I'm the man for the job. And then I couldn't fix him. So I spent 3 hours going back into the operation thinking, there's no elbow here to fix. It's a shell of bone. And you're faced with this horrible situation where you have a young patient on the table that you have already convinced yourself you can't replace, but there is no other option other than replacing it. And therefore, you go into this staged process of, okay, right, make it clean, make sure that we're getting rid of infection, wake him up, have a long conversation with him about what we were hoping for, let's revisit our expectations, what's the next stage. And then it's a whole different probably process, whole different episode of OrthoSpaceX, but going down this route of 3D printed, and I think that's a really we're doing increasingly more custom, as it's sometimes known, or 3D printed implants for solutions that don't exist. So the problems where we have no solution on the shelf, that's when we have to start thinking outside the box. And that's when we're looking at 3D printed solutions, which is, like I said, it's a route you may want to take today, or it's a route you may want to shy away from.
Yeah, well, I'd be interested to know how long that process typically is from seeing that patient to, I suppose, you get the scan, and then does that get sent to the implant company?
That's it.
And how long can that typically take?
So if you say it's urgent, you're still probably looking at the moment in the world because of the Brexit. So Brexit's had a profound impact on implants. So we have our own approval process. So you're looking at around 12 weeks, and that's urgent. So if you've got someone who's had an injury, most patients now would expect to have an operation within 2 weeks max. They all come with this expectation of, I've been told it's 2 weeks max. Otherwise it's wasted. Whereas actually some of the trauma we see, we like to fix within 72 hours. So open fractures, the most devastating elbow injuries, we try and get fixed and sorted within 3 days. And you were saying 12 weeks. So suddenly it's managing expectations and talking to patients about getting the scans, getting them sent off. We have to meet online with engineers. What we're trying to achieve is a joint that looks like the elbow joint. It's got to be stable, it's got to move, and it's got to be strong, because he's a lorry driver. He's got to go and strap the big loads on, he's got to drive, he's got heavy gears and things like that. And then the engineers are like, that's impossible. You're like, no, it's not, it's fine. Like, see that fragment there that you've got on your 3D, that's attached to the ligament. I want you to build me something, a platform to put that on. See that fragment there, that's attached to the triceps muscle, that's the thing that helps him push. I want you to put an implant there where I can attach that on, and you start building up this incredibly complex. See that there, that's the joint, that needs to be really slippy. And they're like, oh, right, we've got a great slippy metal. that'll be perfect for that. And it's great working with engineers because we say this is what we want it to do, and then they're like, well, we have a perfect solution for that. You design a solution, and you get very, very fearful because these are once every 2-3 years cases, and therefore they're very low numbers. In our careers, we might do between 5 and 10 3D printed solutions for trauma, and every one is high risk because it's like last chance saloon.
And I suppose in that 12 weeks, the patient's anatomy could alter again.
Yeah, exactly.
You've been in a position where you've had the custom implant, and because of the patient, during that 12 weeks, it's gotten worse. And the implants
absolutely. And the other thing that's really important to note, and quite funny actually, is that just like people, I hear people talking about sat nav. Trust the sat nav. So when the sat nav says take this junction, you're like, I ain't taking this junction. I've driven this route for 20 years. It's the next junction, and then 10 meters after the junction, it's gridlocked, and you're not going anywhere for 6 hours. So in 3D printed solutions, engineers and computers aren't human. We are human. So if we get a cut wrong by even a millimeter, it affects the diameter, the length, everything, and we will never get it perfect. So there's always this element of fear going into these cases. If I make the cut wrong, I might lengthen their arm and the prosthesis won't fit, so the implant won't fit. I had a situation recently where the engineers had measured the canal of a bone, which is where we put, like, up the middle of a bone, there's a hollow canal, and we wang a stem in, and the stem fixes and integrates to the bone. And the engineer said, ream up to 8 mil, and that's the stem size, and it will go perfectly. And as I'm starting to put the implant in, I'm thinking, this implant is never going in this hole.
Right.
It's too tight. It's engineering at its perfection. And I said to the guy in theatre, the rep who was from the company, I said, I'm really sorry, I'm going to ream up, meaning I'm going to make the hole bigger than what you tell me it should be, because I know that if I hit this in there, it's not going to go in, and I will not be able to get it out. So I just reamed up 0.5 mil, 8.5, and then you just get the sense, right, I think this is going to go now. But that's quite worried. Like, I hit this stem in 1 inch or 4 inches, and it took me about 5 minutes to knock it back out.
Right.
And this is a device. So
if you didn't ream up, it would have been stuck, or you wouldn't be able to remove it.
I would not be able to remove it. You have to split the bone to get it out. So it's and the other thing perhaps it would be nice to mention at this point is GIRFT. So we have this acronym called GIRFT in the UK, Getting It Right First Time. It's actually an NHS funded project that's been running for many years, and getting it right first time is the most important thing in elbows, and trauma is the most difficult bit of elbows. And so we aim to try and get everything right first time, because we know if we don't get it right first time, it's almost impossible to get it right second time, and then not to mention third time. So we try and do the right thing from the outset with the right people at the right time, and that generally leads to the best outcomes.
Do you see a lot of those second and third time operations referred to you to treat?
Yeah, we do. But equally, and to be fair, it happens also in our unit. This is difficult trauma that we're doing. We do get a referral practice in. It's not because of substandard surgery or we're better than them. It's just because we're a big unit that has everything on site. And one of the things that we try and say nationally now about elbows is, if you want to consider yourself an elbow unit or an expert in elbow surgery, you really have to have nerve surgeons on site. That's generally plastic surgeons, because the nerves are so, you think about how big an elbow is, and the nerves that do that all run here. So nerve injury rates are quite high. So you want a nerve surgeon on site. The vessels that supply the blood supply to your hand, they're very small and all quite close by. So you need to have someone that can sort out the vessels. In our unit, we tend to use plastic surgeons again, but sometimes that's vascular surgery. You get a lot of infections in the elbow, so you need a microbiologist on site. You get soft tissue loss, so skin loss, muscle loss. So again, you need plastic surgeons on site, people that are happy to do difficult cases, make up solutions, move muscles around the body to cover things up. So any complications of elbow surgery need to travel to a unit like Leeds or another big unit that can offer all those capabilities under one roof. So I think that's, why we get those cases, and also cases that people don't feel they're either capable of or don't want to take on. Imagine the kind of trauma we see around the UK. They're really challenging cases, and actually it does take a bit of experience, but also confidence that you can form a solution for them. Sometimes I see patients who have seen a number of other specialists where they say there's no solution. I genuinely believe there's always a solution. The question is whether the risk benefit profile, what are you going to lose if we do this and it goes wrong? What are you going to gain if we do this and it goes well? What does the weighing scale say? And what's your decision? And what do you need to know of me to make that decision? It's never that I tell a patient, I have a solution, I must offer you that solution. It's saying to the patient, this is the solution, or these are the solutions that I can think of. This would offer you X, this would offer you Y, this would offer you Z. What do you want to do? And what do you need to know to make that decision? And that's the consent process. I'm very blessed with great colleagues, plastics, microbiology, orthopaedic colleagues, upper limb surgeons that I work with that are very supportive in having a very, very niche practice. You can't work in a unit offering those kind of solutions if you don't have people around you that challenge you, tell you when they think you're wrong, but also support you when they look at your solution. They go, wow, that's the only thing you could possibly do. And
And do you personally find those rewarding, fulfilling when the patient's perhaps been told there's no solution? You fix them? And is that something that still drives you in your career?
100%. Like, great example, without kind of naming any kind of names or skewing. I saw a guy recently who had a fracture of his elbow. He has a congenital condition, which means his elbow's not normal, and the fracture was not fixable, and he really struggled. And we 3D printed him half an elbow with all these platforms to put everything back on that we needed to put back on to make it stable, move, pain-free, strong. This is a guy who has short arms, who still plays able-bodied rugby, so he can still smash people. And I was like, when I first met him, when he had his injury, I said, there's no solution. There is no solution to this. But I maybe stupidly said, the only thing you could possibly do is 3D print the same shaped elbow off the other one. We could, so then 6 months later, when his arm doesn't work, it's stiff, it's painful, and he can't function as a father, and he can't do what he loves doing, which is play rugby, he came and said, you said you could 3D print my other elbow and flip it like a mirror and stick it in this side. Can you do that? And he's done really well, and that's great. Now, but as soon as you ask the question, the thing I want to make clear is it's very stressful doing our job, and at times it's actually quite emotional, because whilst we have great stories like that, we also have stories where, not promise, but we say to patients, I think I have a solution for you, I think I can help you, and things go wrong. We're not God, and I do get complications. I'm very comfortable talking to patients and colleagues about complications, and elbow surgery is fraught with danger, and that's why the UK has tried to centralise elbow surgery into fewer units, so that we do higher volumes, so that we get better. It's not that we are better, it's that we get better because we're doing more complex cases. And I've learned so much over the last 10 years doing complex elbow surgery, but I can name you, I won't name you, but I can name you, and I know what they look like, and they might see this video, and they know who they are. And if they're watching it, then they'll know that I'm talking about them. but I can name you the people in my career who have had devastating complications of difficult surgery that hasn't gone well. Now, I'm lucky in that the positive spin is what you talked about. It makes me fulfilled in my job. It makes me excited. It makes me happy seeing patients getting better and me having solutions that can see their problems. But I always offset that with my humility side where things don't go to plan.
Yeah.
And when I speak to other people about these cases, I make sure really clear that they know that this is fraught with danger, there's complications. I tell them about my complications so that they know what they can expect. I mean, imagine going into this guy's arm without normal anatomy. So he's born with an elbow that we don't know what we're going to find. We don't know where any of the nerves are. We know we've got to put in a 3D printed prosthesis that's based on his other elbow that we assume is the same shape as this one. It's not a normal elbow like mine. It's born with a different shaped elbow. You just don't know what you're going to get.
Yeah. And would you say the elbow community is generally very supportive? Or...
Yeah, no, it is. So we're a really tight group nationally. We definitely have differences. So we talk about like the word disciples is a great word, isn't it? So you're a disciple of, and you can spot, if you're an elbow surgeon, you can spot someone that's been trained by Sam Vollans in Leeds. You can spot someone that's been trained by, let's say, Adam Watts in Wrightington, Joe Fadness, and they speak the same. It's like the football, you're an Arsenal, I knew you were an Arsenal fan, or I knew you were a Leeds fan. You can just spot their kind of behaviours and how they speak. And that's fascinating. But I think it's amazing. So I guess I should mention Amjad Ali. Amjad's a very good friend of mine. He works out of Sheffield, fantastic guy, fantastic brain. But I teach regularly with Amjad on courses, and Amjad is a fantastic guy. I've learned everything I've learned off him and David Stanley. I'm a disciple of David Stanley and Amjad Ali in my elbow practice. And then about maybe 6 months ago, Amjad just whispered in my ear, really like whispered. He was almost like, and he'll find this funny if he sees this video. He whispered in my ear, your approach for elbow replacements. I started doing it, and I literally I felt warm inside, because the thing is, I learned the Stanley approach off David Stanley, and that's their approach, and that's what I learned from them. And then I came to Leeds, where my true kind of Yoda is Dave Lim. So Dave Lim, big shout out to Dave Lim, absolute legend. And Dave has always done the approach the same way, and I went back to the Dave's approach because I thought it was brilliant. And then Amjad now is like, I do your approach for primaries. And I was like, this is brilliant. So we learn off each other.
Yeah, made it.
Yeah. And Dave's brilliant. So we have a great, me and Dave have a brilliant relationship. So I've known Dave since I was 18. Right. He was the person, probably, I didn't mention it earlier, he was probably the person in my life that made me choose shoulder and elbow at uni. That's where I wanted to go at university. And he was a senior lecturer in orthopaedics, and I'm very blessed because he's now my senior colleague, so I work under Dave. Though it's amazing, the last few years, Dave constantly says, speak to Sam, I've got no idea. And that's it, innovation. Dave's at a stage in his career where he would say, if he was here, I'm too old to innovate because what I do well, and my results are brilliant. Why would I, in the last stages of my career, start doing things that are really niche when I'm leaving, and I'm going to leave all that behind for someone else? And that's really, I'm not there yet, but I can see that, how he's like, well, you innovate, I'll support you in innovation, because you're going to have to deal with the consequences of innovation in 10 years, whereas he's not. Yeah.
And that makes a good team.
Yeah.
I suppose you've got different.
If you think you know it, if you think you know it all, you don't know anything. You've got to constantly be learning from other people. And there's some fantastic brains and abilities around the UK. And it's too many people to name. I don't want to name and offend anyone, but you know who you are. You. We're OrthoSpaceX are coming for you. Some fascinating people. Have you done it? I've got. Can I mention another name? Am I allowed to?
Yeah, you can mention.
Yeah. So, have you interviewed Lee Van Rensburg?
No.
Right, Lee Van Rensburg, you crazy guy. these guys are coming for you. He's absolutely brilliant. Great brain.
Yeah.
Yeah.
I saw actually the you did an elbow talk together online. Is it BMed or something? There's a
Yes.
elbow.
Yeah. BMed's like a European thing. Yeah.
I remember you were both on there as.
What were we talking about? Elbow.
Something else.
Elbow. Yeah, that's awful. But yeah, he's a great guy. He's got a great brain, and he's a real antagonist in a good way. So you say X, and he goes, but why not Y?
Yeah.
And you're like, well, I never thought about that.
And that's healthy as well, isn't it?
That's great.
It's
really good. Yeah,
a good conclusion.
He's a great guy. I'd love to know. Also, the reason why I'd love OrthoSpaceX to interview him is because that kind of behaviour comes from somewhere. So I'd love to know more about Lee's background.
Yeah.
Lee,
we'll have to get you on the show.
I've set him up, right? I've set him up.
And finally, what do you think are the most important things for early career surgeons who have maybe not yet decided whether to go down the route of treating complex elbow fractures or elbow in general, and are thinking about going down that route of specialising in elbow? What advice would you give to those?
I guess the first journey that I went on is why. So why are you wanting to pursue that? What is it that draws you towards it? I think often it's the people. Often they'll meet Lee Van Rensburg, maybe me, maybe Adam Watts, other big names in elbows. They meet them on a course, and Sean O'Driscoll, what a great guy in America, may have done it. So if you
cool guy.
Yeah. No, but if you meet quirky people that have something about them, you're like, I want to do what they do. In every walk of life, fashion, sport, you meet someone that's cool, you're like, I want to be like them. So that's the first thing. Why? And then I would probably say to them, make sure you know where you're going. So there's no point in having the why and then knowing how you become that without knowing where you're going. And the reason why that's important is like when we interview people for jobs to train them in complex elbow. So I have like a thing called fellow, which is a very senior trainee, someone that's finished all their training, they're ready to become the boss, but they just need honing for 6, 12, maybe 18 months in what they want to be a boss in. And they come and they say, can I come and work with you? And you're like, yeah, of course you can. We're going to be doing arm transplants, adult and children's complex elbow, orthoplastic infection cases, 3D printing, all this complex stuff. And then they go, oh, it's amazing. I can't wait to work with you. And then you say, what's your career plan? And they say, well, I want to work in a smaller hospital on the coast, where they don't have plastics, they don't have an HDU, and you're like, that you're not going to be able to use any of these skills. It's got to be like what we call congruent. It's got to make sense. Your journey's got to make sense. So I'd say to people who want to do complex elbow, they already know why they want to do it. They probably know where they're heading. So for those people that know why they want to do it and they want to work in a big unit that can deliver complex elbow, then make sure that you get a really good fellowship that does high volume trauma. That's really important because elbow is quite unique in that trauma is where the hard stuff is. Elective is a breeze. Planned surgery is a breeze if you're good at trauma.
Right.
It doesn't work the other way around.
But like driving a manual car versus an automatic, perhaps. If you can drive a manual, you can drive an automatic.
That's
an automatic.
And it's not to undermine other subspecialties, but if we look at like hip surgery, just hip surgery, on paper, hip surgery is like 80-90% hemiarthroplasty, that means half joint replacement for fractures or fixing fractures. Now those are the kind of operations that we would leave a trainee to do by themselves, and they would be great at it and the patient would do well. A complex hip revision operation, you would never leave a trainee to do it. It's often dual consultant operating, it's complex, people can die during the operation, it's difficult surgery, versus a Monteggia variant, so it sounds a very complex name, but a bad elbow injury that sometimes even consultant shoulder and elbow surgeons get wrong versus an elbow replacement. Elbow replacement actually is easy. It's an easy decision to make. Make a hole, put a hinge in like a door, stitch them up, they'll do okay. Here, they could get nerve injuries, arterial injuries, lose their arm, end up with an elbow that doesn't move, is painful, stiff and unstable. Like, it can go so wrong here. So 6 months minimum, if not 12 months in a big unit that does loads of trauma, and then an add-on of an elective fellowship. So I would do 12 months in trauma and elective, and 6 months in an elective unit, just doing the routine elbow practice. And I think that will make you a world-class elbow surgeon from day one.
Yeah.
That's my point. And come to meetings, chat to people about elbows, shout out to Cubitus Mundi, massive elbow group across the globe. Join Cubitus Mundi, go visit people after you become a consultant, because you can learn, once you become a consultant, in 2 weeks, you can learn what you would in 6 months as a trainee. Right. So I did a visitation. I went to see Adam Watts in Wrightington to learn a particular elbow replacement that he does. And that was fantastic. I went for a day and that was enough. And then I went to visit for a few weeks Denise Agendahl, fantastic surgeon, professor of elbows in Holland, and Roger van Riet in Antwerp, fantastic guys. I would go visit loads of people. You just can't spend the rest of your life traveling around the world visiting these people, but choose a few people that do things that you want to do, and then start your consultant practice in a unit. Last bit of advice: in a unit where you're supported and you've got a great team, and you don't feel like you're going into a unit and then you're left to your own devices. You don't want to be left to your own devices. If you're left to your own devices in complex elbow, you'll struggle. You've got to have a great team.
Yeah. Brilliant. Well,
is that right?
Thank you, Sam.
Thanks for the invite.
And for everybody watching, big thanks to Sam for joining today. And please follow, like, and subscribe to OrthoSpaceX, where we share exciting stories with some of the greatest minds in orthopedics.